Good afternoon, everybody. This is Samantha with the Law Offices of Samantha Wolf, and I'm here with our latest installment of Partnering with the Pros. And I'm excited to have Dr. Tim Davis here with us. Thank you, Tim, for being here. We really appreciate it. I wanted to, and I know that you and I had met previously, but just to kind of give clients some background, I had met with Tim a couple of months ago, and at the time I had a client where I was acting as their financial power of attorney. It was one of those things where the timing just worked out perfectly. My conversation with Tim, we were talking about cognitive concerns as people age, things like capacity. And we met and he started mentioning that he does assessments for people. So I said to him, we do a series Partnering with the Pros. Would he be willing to jump on here, chat with me a little bit? So thank you, Tim, for taking the time. I really appreciate it.
Sure, I appreciate you having me.
So I want to give everybody a little bit of background. I have his biography here, so I want everyone to know a little bit about Tim. Just know that we will drop his contact information, contact details in the description of the video when we do upload it. So if anybody wants to get in contact with him, we'll make sure to have that. We'll also put a little bit of his biography in there. So Tim, just humor me. Let me outline your biography, and then you can offer any comments that you want about that. So
Sure.
we have that you are a clinical neuropsychologist and you're a native of Chambersburg, Pennsylvania. You completed your doctoral degree in clinical psychology at the Philadelphia College of Osteopathic Medicine in 2008. And then in 2014, you completed your 2-year postdoctoral fellowship in neuropsychology at the University of California, the Davis Medical Center. And there, when you were there, you got to really focus on Alzheimer's disease by working in their Alzheimer's disease center. Is that correct?
Yeah. They have one of the National Institute of Health. They have what they call Alzheimer's disease clinics spread out throughout the country where they do research and provide care for the community. And I had a wonderful opportunity to work there.
Did you have an interest in that before you started working in that center? Okay.
Yeah. Aging brain has always been just an interest of mine. Just there's so many interesting things about it.
That is true. I do think that you're right about that. And I always grew up, grandparents, I had some great aunts and uncles. And I just remember as they would age, some of them would live with us or we'd providing care for them. And it was always interesting to me, things that would affect their cognitive function. Certain medications affect cognitive function. And then, of course, the whole aging process. So you're right. It's definitely a very fascinating thing. Now, the other thing I wanted to mention is that you served as an active duty status in the United States Air Force for 10 years with one deployment in Afghanistan. And then you did complete psychological evaluations at the Veterans Administration Medical Center, which I bet was a
Mhm.
fascinating experience as well.
Yeah. We had a number of different issues related to military service, but then you overlay on top of that, we get older too. So as we get older, we start having some changes, and so it was a good opportunity to evaluate it from both perspectives.
Do you see a difference as people who have served in our armed services? Like, do you notice a difference as they age?
Not really. The kinds of medical problems they present with certainly uh, can be a bit different in terms of a lot of diabetes amongst the Vietnam veterans was something that went along with the Agent Orange that they had been exposed to. So there's some dementias that are more related to diabetes with the VA, whereas outside the VA, you tend to see a broader spectrum.
Oh, that's interesting. Okay. But then you are now back at home in Chambersburg.
Yes, it's nice to be home after all these years, and the place has definitely grown.
Yes,
And
I feel like that area, it's getting very big. A lot of people have moved in. Yes, absolutely.
so
Absolutely.
lots of new opportunities here. So happy to be back. I was halfway between work, and we're caring for our moms as they're aging. So it was a really good point for us to come back.
Good. Good. Tell me, just to kind of open us up as we're having this dialogue back and forth, tell me a little bit about what you do in your own words.
Sure. So with neuropsychology, basically you're measuring thinking, various kinds of thinking in terms of memory, attention, language abilities, problem solving abilities. So all of these different things that we think in our head, we find ways to measure them. So
Mhm.
we employ a number of different tests. It could be just asking questions back and forth. It could be pencil and paper type things, sometimes or on a computer. But we have a number of different ways to measure a number of different cognitive abilities.
And that's really what you're trying to do, right? Measure it for whatever purpose you need to have it measured. Is that correct?
Correct, correct. So whereas like an MRI would be able to show you, pinpoint where the location of a stroke may be, and can kind of give you some information about what someone might expect after a stroke. But what an MRI can't do is tell you how much that has impacted somebody. So, for example, if somebody has a stroke in a language center, we would be able to measure how much of a change there has been because of that stroke.
Oh, that's interesting. Okay. Now, when you're able to measure it, is that measurement just important to know like cognitive decline? Is there anything that we can do to improve any type of decline that people have?
Certainly, there's some things or some conditions that respond well to treatments and interventions, and some that don't respond as well. So your things like Alzheimer's disease, cerebrovascular disease, there's not much that can be done to improve those conditions. There are some things that can be done to slow the progression of decline, but there's not really much at present to do to improve those conditions. Whereas, like with a stroke or traumatic brain injury or something of those kinds of presentations, there are things that we can do that can help improve functioning after those kinds of events.
Okay. Now, I had told you a little bit about this, like I said, when we got together, but that client that I was acting as power of attorney for, it's interesting to me that from a legal standpoint, capacity is something that's very fluid, right? Like people can be more with it certain times of the
Mhm.
day, as opposed to like in this situation, the client was more with it in the mornings, and there was definitely a cognitive decline as the day went on. Then she'd wake up, have a little bit of a refresh and be
Yeah.
more lucid and more clear as far as her thinking. So I think that's an important thing that I wanted to make sure clients, especially those that might be children and her caretakers of parents, is that it's not linear as far as
Yeah.
capacity and cognitive function. It can go up and down depending on what the environment is. Is that true?
Mhm. Yeah, yes. So, depending on the supports that we're able to get in place for people, that's certainly one thing that can be helpful. But yeah, capacity can change. It changes with medical conditions, it changes with environmental conditions, things going on in the home. There's a number of different things that affect how we think. So capacity is something that can be changing over time, either direction.
Yes. And in our office, we notice sometimes the largest decline that we see is when one spouse passes away. We
Yeah.
see a cognitive decline in the surviving spouse. And I've always wondered, is that directly tied to that emotional and traumatic event? Is it something where that triggers it? But it's definitely something we've seen over and over with clients.
Yeah, it certainly is. It's a big adjustment in and of itself, and just losing somebody that close to you, that in of itself can affect cognition. So
Yes.
the process of grieving, which is natural, does have some effects. So you can see some signs of cognitive difficulties just from the mourning process. But oftentimes, as we age with our spouses, we tend to take on responsibilities for others. I'm not the best at paying bills, so my wife does that. But so you wouldn't see me having problems paying bills unless she were to pass. That's when that kind of thing might show up that, okay, I do have a problem with this. I haven't been able to do this for a while, and I no longer have that support. So
Mhm.
it's about finding ways to provide that support, or finding ways to address the whatever it is that's causing those cognitive
Mhm.
difficulties, and finding ways to mitigate that.
Is stress something that can cause cognitive issues, lapses, I guess, if you will?
Yes, certainly. Thinking and emotion are tied so tightly together. It's an important function to have. If you see at the tiger, you want to have an emotional response so that you get your attention to it, and
Mhm.
pay attention to it. So emotion and cognition, they go hand in hand a lot, and
Mhm.
emotions can affect cognition. So things
Mhm.
like depression or insomnia, anxiety is another big one. So they can cause depression just by the emotional component. But
Mhm.
over time, there can also be an additive effect. So, for example, with anxiety and cortisol, cortisol levels increase with anxiety, and prolonged exposure to increased cortisol levels can all have a long-term effect on cognition as well. So there's the emotional response to it. There's also a physiological component to it too.
With the thought being that if you were able to remove that stressor, would cognitive function rebound?
Yeah, you would expect to see some cognitive improvement with mood, whether it be depression or anxiety. So that's one of the things that we actually evaluate for as part of the evaluation, is to tease apart different factors that might be contributing to cognitive difficulties, like whether it be mood, or it be medications, or it be sleep, or it be pain. And there's a number of different things that cause problems with cognition that we don't think of. And they're not things like dementia, they're not things like stroke, but they have the same kind of impact. So it's about identifying what's contributing to those cognitive difficulties and figuring out what can be done for that.
Is that one of the things you can do? Can you identify where there might be or reasons why there might be a cognitive decline, like depression, anxiety, all of that? Okay.
Sure, sure. So we look for certain profiles. We measure different areas, and then some will be high, some will be low, and different conditions have different profiles. So we're looking for our a profile that we would expect for a given condition. And if
Okay.
that's a profile that we get, then okay, that reinforces the idea that it looks like depression might be contributing to this. Um, if it doesn't fit with the profile, then we need to go back and dig a little deeper, and figure out what is causing this profile. And it's an interesting process. It's kind of like being a detective in some ways. It's like, okay, trying to figure out what's contributing to this. How do we get here? Um,
Mhm.
and so yeah, so then we look at the profile of scores, and that can help to differentiate what might be contributing to the cognitive difficulties they're experiencing.
Because the thought being that if you had something like anxiety and you're able to treat that, again, that might
Mhm.
help cognitive function.
Yes, yeah. So if someone presents with some significant anxiety, you would expect to see some cognitive improvement just by treating the anxiety.
Okay. Okay.
Yeah.
Now, Tim, I have a rather unusual question. And the reason why I'm asking this is because when I was visiting my doctor's office, they had pamphlets. And so I want to ask you something specifically. So when I was in there, there was a pamphlet about menopause. And one of the things it was saying there is how hormones can affect cognitive function. And they were actually saying that sometimes when women go through menopause, they have some cognitive concerns as well. Is that
Mhm.
true?
Yes, yes.
Okay.
It's one of those things that one condition can affect another condition, and menopause is certainly one of those, where just by going through the process of menopause can cause some problems with cognition that wouldn't expect to be there on the end of
Okay.
menopause. You would expect that once the menopause has run its course, that cognition would return back to its original baseline.
That was
But
just so interesting to me because I meet with clients all day long, and I'm always surprised when people come in and they'll say, like, mom specifically, we've noticed she's forgetting things. She, can't remember what she's doing. Sometimes she gets overwhelmed easily. And, to kids, that's a big deal. They're noticing mom's always had it together. Mom always
yeah,
used to know what she was doing when she was doing it. And I think that I always encourage children to recognize that there could be these other medical influences
mhm,
that could be affecting someone that may have previously not had an issue in that area.
exactly. And that's a good time to have that kind of conversation with the primary care doc who would be able to navigate, because what's going on in your life right now, looking at things medically, but also looking at things, socially, environmentally. And they would be able to provide the information that, yeah, this is not necessarily something we wouldn't that wouldn't be unexpected. We would expect that you're going to have some difficulties with cognition, so this is more of a normal experience, and then that can help someone kind of prepare to navigate that.
Right. The other
Yeah.
thing I've noticed is clients that come in, they'll say things like, I'll ask how they're doing, are they having any memory issues? And they'll say something like, well, I'm really good for 87 or whatever the age is. And there is
Uh-huh.
some truth to that, right? I mean, there's a natural cognitive decline as we age. And so there is such a thing as being good for whatever that age is.
Hmm. Exactly. So as soon as we hit 30, we start to slide in some areas. So we would expect somebody who's so we wouldn't expect somebody who's, say, 30 to have the same cognition as somebody who's 16. We also wouldn't expect somebody who's 76 to have the same cognition as somebody who's 30. So we
Mhm.
have different norms for different age groups, and we look to identify what is normal for aging.
Okay.
And are we seeing a score that's kind of outside of that range, or are all the scores kind of hanging nicely together, where we would expect them to be for somebody who's 76? So we definitely look at age as being a big factor in that.
Well, I also think too, just as a society, we need to stop assuming because somebody is having some cognitive decline or cognitive issues, doesn't mean they're incapacitated. We're very quick to be like, oh, this person's incapacitated, when in
Mhm.
reality, our job is to allow them to be as independent for as long as they're able to be. So if that means that we need to rearrange the schedule, when we're scheduling a signing for clients, one of the things we
Mhm.
ask is, what's the best time of day? Do we
Yeah.
need to see them in the morning? Do we need to see them right after lunch? Because we want people to be retaining as much independence as they can for as long as they can.
Yeah. Definitely. And when you hear someone raise the idea of having a capacity evaluation, that can cause some anxiety and some fears in of itself. But really, what it's about is about identifying: is there something that would prevent you from being able to make a decision that you normally would make? And if so, what can we do to provide some assistance with that? And that's really the heart of it: is how can we help work around this difficulty that's presenting itself?
Mhm. Let's move a little bit. I want to talk because we've been talking generally about all the different ways that cognitive function can be affected. But let's move a little bit and let's start talking about where do you come in all of this? So, when should we rely on someone like you? When are you needed? And I know recently I had a client, I'm co counseling with an attorney in Virginia because we had a client who resided in Virginia, relocated to PA, and the individuals in their 90s, and the concern was, did they have enough capacity to be able to execute new documents? And when I was speaking with the Virginia attorney, I said, well, we can get a doctor's letter to
Mhm.
weigh in on capacity. And she said, no, I really think we need an actual clinical determination about capacity. And that's where I was so thankful that I had met you because we referred them to you. So let's talk a little bit about in what situation do we need someone like you?
Sure. So, um, There's generally two ways that people will present for a neuropsych eval. One would be medically, another would be legally. So with the legally, it's being able to establish that somebody is has the cognitive ability to to understand information that's being presented to them, being able to critically think through these kinds of things, and being able to express a choice. The American Bar Association, American Psychological Association actually got together and put together some pretty good guidances on this, so that if somebody is, needing to participate in some legal activity, whether it be, doing a will, or doing power of attorney, you know, is there anything that would interfere with their ability to make good, sound decisions with that? And so when somebody comes to that life point where they need to make a will, or they need to draw up a power of attorney, that could be a good time to call in a neuropsychologist if there's concerns that the age has progressed, or something else has happened that might be drawing cognitive abilities into question. So that would be a good time to engage a neuropsychologist on the legal end. For the medical end, generally it comes through primary care physicians and neurologists. So that's generally where people will start if they notice problems with themselves. My memory's not quite as sharp as it used to be, or it takes me longer to work on things than it used to. So those are the kinds of things that are good to present to your primary care doc, who then would send out for any testing that would need to be performed, and that's how people arrive to a neuropsychologist from the medical side.
Okay, that makes sense because I could see where legally, of course, I know when I would need someone like you, but
Yeah,
medically, I feel like there would be a need as well to be able to evaluate that.
yeah.
Absolutely. So now, is it a situation where there's not an attorney involved, there's not a physician involved, but someone can reach out because maybe a family member has concerns about cognitive function for someone?
Mhm. Sure, they certainly could. And I do get some people who will call directly. Um, Sometimes we refer them back to their primary care physician so that they can submit a referral. If they submit a referral, then Medicare or healthcare insurance would cover the cost of the evaluation. But if somebody is wanting to pay out of pocket, and sometimes that's the case where they don't want to work with the insurance company, they can just call directly, and we can get things set up from there.
Okay, and tell us a little bit about the process so that if somebody would need your services, it's not a surprise to them how you go about doing it. So tell me a little bit about your process.
Sure. So whether they call directly or a referral comes in from a primary care physician, first thing we'll do is we'll schedule a time to meet. And then the whole process will take about 3 hours of face-to-face time. That's 1 hour of doing an interview, getting a better understanding of the history behind whatever is bringing somebody in. But also looking at, childhood developmental things. Serious illnesses during childhood can have, an impact on cognition when we're older. So we want to do a good history taking, and also want to get a better idea of the specific concerns that people are having, the things that they're seeing, because then that will then drive the next part, which is doing the cognitive testing. The cognitive testing looks at all areas of cognition: memory, attention, problem solving, visual spatial abilities, but also looks at personality and mood, depression, anxiety. So we'll be employing some tests that measure all of those areas. Some of the things are really, really easy, and some of the things are really, really hard, but that's the idea. If we gave everything that was easy, it wouldn't tell us anything. So we kind of have to take somebody to the point of failure to find out where that point is. And just because they get to that point where they're not doing well anymore doesn't mean they're not doing well. It could be very well what we expect for somebody at that age.
Right.
But it's the cognitive testing, and it's the clinical interview and review of the medical records are the main components to a neuropsychological evaluation.
So do most individuals who come to you bring their medical records, or it's just more of an interview that you ask the question for?
It's a mixture. It's always helpful. The more documentation we have, the better of evaluation we're able to perform. But some people don't have access as easy to their medical records as others do. So we'll do a good, thorough clinical interview. If we need any more information, then we can reach out to the person's primary care doc and see if we can get some more information from them.
Oh, very nice. So when I would come in to see you and you're walking me through this,
Mhm.
I already know, because I know I myself get a little bit of anxiety when I go to the doctor. So this is not like a test where you're like passing or failing. This is just really a discussion that somebody's having with you to be able to determine where you would be cognitively.
Yes, it's looking for strengths and weaknesses, and what those strengths and weaknesses mean for somebody's everyday functioning. We all have strengths, we all have weaknesses, um, and that's normal. But
Mhm.
it's helpful to know where those strengths and weaknesses are because we may be putting ourselves in a situation that's playing to our weakness, and we want to do something about that.
Sure, absolutely. Plus, I think information is always powerful. It allows you to be able to adjust, especially if, like you said, there are other factors that might be contributing to it, anxiety, stress, depression. To be able to address those concerns might allow you to get some of that loss back.
Mhm. Yes, and there's what they call reversible causes for dementia, and that's the things like the depression, problems with sleep, the medications that we take. Sometimes they can cause problems with memory. For example, sleep medication can often cause problems with memory. So, being able to identify all of these different factors, it's not always just about the physiology in our brain. Sometimes it's about something that we're doing in our day to day that's contributing to these problems.
Let me ask you about specific medical conditions. So, for example, I don't know really anything medically, but I do know from being in this area of law that sometimes if there is a drastic cognitive shift that really
Mhm,
isn't explained by much, one of the things that I always ask clients is, do they have a UTI?
mhm. Yes,
Because
and
it's not
that's
usual to have a big shift
uh-huh,
cognitively. Like there's usually some sort of medical reason for it. And if they've ruled out things like stroke, all of that, we
uh-huh,
just have had a lot of clients that become disoriented with a UTI.
and that's very common. Um, UTIs or other conditions or illnesses can present like or look a lot like dementia, but really it's not.
Right.
And then just treating something as simple as UTI can get somebody back to their original baseline of cognition. So
Mhm.
it's yeah, a number of different things that can cause cognitive problems, not just the ones that we tend to jump to like dementia or stroke. It's some really basic things sometimes. Vitamin D levels, for example. Vitamin D is important for formation of new memories.
Mhm.
And so if somebody's not going outside, they're not getting a lot of vitamin D3 from the sun, that can affect memory.
Oh,
So, it's identifying all those factors and kind of setting up a plan for how to address each one and see what kind of cognition we're able to get back from that.
Oh, that's interesting. Yes. I just always am suspicious if somebody has had a very quick or sharp decline in cognitive function.
Mhm.
Usually that's not dementia or Alzheimer's. Usually that's some sort of medical condition that has caused this. And so when families come in and they say, mom was fine up until, 3 months ago, and all of a sudden, then it's a question of medically what is going on. Because I think dementia, Alzheimer's, all of those are more gradually you notice these changes in someone.
Yeah, they're slow, they're progressive, and because they're slow, we don't often notice them early. And but that is a slow process. And if there's an abrupt change, really the only kinds of things that would explain that. outside of other medical conditions, like you would expect to have a a significant drop with a stroke or traumatic brain injury from a car accident. But if there's a change in cognition without those kinds of things, oftentimes it'll be traced back to some other medical condition, like a UTI, or they might have developed Lyme disease and didn't
Mhm.
know it. So
Right.
those kinds of things can really change somebody's cognition pretty quickly.
Well, it's interesting to me just how much little things affect. A couple of years ago, I had low magnesium, for example, and I just happened to mention it when I was in an appointment with a physician, and he happened to be a pain management specialist. And he said, if your magnesium is low, your pain is more acutely felt. So to me,
Mhm.
like, for example, I remember having really bad hip pain that day, like to the point where it
Uh,
was difficult for me to stand. And when he said that, that was so fascinating to me that if you bring your levels back up to what they're supposed to be, maybe that pain then isn't really there.
mhm.
So, or
Yeah,
not as acute as you feel it.
yeah, it certainly exacerbates the pain experience when the levels are low. So
Yes.
sometimes just getting the levels back to where they need to be can get you back to original functioning.
And even things like we need to think through, especially if somebody's living by themselves, sometimes eating is a problem because you don't really like to eat by yourself, right? We've made in
Mhm.
the United States, food has become a way that we bring people together, and that's great until you're by yourself. And if you aren't eating, then certain nutrients might be deficient. And so it's always important to investigate the underlying medical aspect of those things.
Definitely, definitely.
Okay,
Yeah, and
so let me ask, how often do you assess someone? Is it something where you have to assess an individual multiple times? Is it a once and done? Tell me a little bit about that.
sure. It really depends on the situation. So for things like tracking dementia over time, repeat evaluations can be very helpful because that can establish how much change there is from one year to the next. So in those kinds of situations, when we're tracking somebody's cognitive decline over time, we may see them once every year, once every 2 years to measure if there's change. But for things like a capacity evaluation to be able to fill out paperwork for, a surgery you're going to consent to, or for a will that you're looking to have written, that would be pretty much a one-time thing where you do the assessment, find the level of capacity, make the recommendations for some improvements, and then they go off and they do their thing, and
Mhm.
that's really all that's needed at that time. So there's different reasons to track, but oftentimes there's no need to.
Okay. Have you ever been called for testimony in a court case related to capacity?
Yes, yes, I have a couple of situations, and it was helpful for the family. It's can be put in some tough situations sometimes, trying to convince somebody if they are having, some difficulties in the cases that they are actually having them, it can put them in a bad spot. Whereas, having a neuropsychologist come in and being able to actually measure and say, okay, yeah, what people are seeing is pretty much what they're seeing. And that can be an easier way to receive that kind of information for some people.
Oh, sure, sure. It just occurred to me when you were talking about capacity where I could see if there was a question where they would call you in to testify about it. So that's actually the first time I'd even thought of that is when you were describing that. So that's interesting to me.
Yeah. Yeah,
So
so it
describe
was
a current
I'm sorry, say again?
situation when you've had to, like a recent evaluation. What were you evaluating for?
For somebody I had recently seen was going to was for financial capacity, being able to make financial decisions. So we did a full evaluation looking at all the cognitive abilities, but we also do some more specific testing around, the functions that they would need to be performing to make financial decisions. So we were able to measure all of that. So doing a clinical interview with the individual, family members. Lo and behold, they were found not to have any cognitive problems at all. So
Oh,
that
that's
there turned
wonderful.
out to be no things that we needed to put in place in order to help that person be able to make decisions, because they were able to, and those were the happy ones. We like to always give good news like that.
Oh,
So that was
absolutely.
a fun one.
Now, is it usually just you and the individual in the room? Is that typically how you do your interviews?
Well, the interview, we encourage family members to come in. Sometimes we aren't as aware of some of the difficulties we're having, and that's where somebody's spouse or somebody's child would be able to provide some additional information that would be helpful. So having family or friends there for the interview is always a helpful thing. But when it comes to the testing, then it's one-on-one because we don't want any distractions. So we
Hmm.
want a controlled environment where we can get the individual's best performance. And so that's a one-on-one kind of engagement.
Oh, that makes sense to me because I feel like you need to make sure that nobody's influencing any decisions that they had made when they're
Yeah.
going through those battery of tests. Yeah. And it's usually all at once, Tim. I know you said about 3 hours, right?
Yeah, generally, if we're able to do 2 hours of testing in all one stop, we can do that. But if we need to
Okay.
break it up, we can do something in the morning, something in the afternoon. If it's a really long testing session, we can break it up over a couple of days. So there's ways to work with that, because one thing we don't want to be measuring is fatigue. So the longer we test somebody, the more fatigued you become, and then you get to a point where you're no longer measuring cognitive ability, you're measuring how tired somebody is. So we want to
Mhm.
keep it within reason. We try to keep it in shorter blocks if we can.
Okay, that makes sense. I know one of the things that because we had emailed you some questions. One of the questions I found the most fascinating was your answer to the cost, because you gave such a large range. If I were to Google it, what would something like this cost? So talk to me a little bit about that, because that was fascinating to me.
Sure. So yeah, if you Google, how much is a neuropsych eval cost, it can cost up to 7,200. Now, those are very highly specialized. So it's kind of unfortunate that's the first thing that comes up with Google, because really a neuropsych eval is going to cost about $300 or $400.
Okay.
And oftentimes it's covered by insurance. The types of evals that you see are for those like 2-day evals that really are kind of how we used to do it.
Hmm.
But with there's being more need, better tests that are shorter, we don't have to go that long. So
Okay.
yeah, if you see those big numbers jumping out, don't pay them any mind.
Let me ask you, I had a client who came in, this has been a little while ago, whose physician, their primary care physician, had indicated that they should not be driving. And so they did whatever they needed to do with the state. The person lost their license and she was understandably upset. When I met with her, I didn't think she was cognitively impaired at all. She seemed perfectly fine. So I guess she had gone back to the doctor and kind of said, hey, this is not legitimate, like I'm good. And the doctor was fighting now with the state in order to get her driver's license reinstated. Have you ever had situations where you've been called in to weigh on someone's capacity related to that?
Yes, certainly. Um, is There are some neuropsychological tests that are helpful in helping identify somebody's ability to drive safely. It's not as good as, say, a driving test. Those are the best that are available out there. But there are times when somebody's found to have problems with memory, or they're having problems with divided attention. They can't pay attention to the car across the road there, and the little child bouncing a basketball off to the side. So we can measure those kinds of abilities and identify those kinds of risk factors. So if there's cognitive impairment and the individual or there's been some signs of cognitive impairment that's caused for somebody's license to be suspended from the state, you can have cognitive testing to actually test for, are those cognitive difficulties actually present? And so
Okay.
I've been called into for some of those as well.
Okay, gotcha. Can you tell me if let's say that I go visit my mom and I think that there might be some cognitive decline, but I'm not sure, but
Mhm.
I'm concerned about it. Are there things that we can be looking for as signs that maybe there might be some cognitive decline?
Yeah, some of the things that might show up early, misplacing or losing items that are important, car keys, glasses, things like that. So if there's an increased tendency to start losing those kinds of things, that can be an
Mhm.
indicator.
Now,
Also, sorry.
you there. I have a sister who loses her keys all the time. So this would be someone that didn't normally lose items that all of a sudden is okay. I just wanted to make sure because
Yeah, I'm sorry.
to let my
Yeah,
sister know she come for an evaluation.
yeah. So yeah, we're definitely talking change. So if
Okay.
they, you know, lost it every other month, that's history. That's fine. That's actually not a problem. But if they
Okay.
start losing it every other week, that's a change for them. That's an observable change. Then that could be meaningful.
Okay.
Um, Other things are starting to have difficulty with using technology like phones, remote controls,
Okay.
um, microwaves,
Okay.
things that they were able to operate before, but it's starting to be a little more difficult for them. That can be another indicator.
Okay.
Um, if you notice someone is repeating questions, they ask, where are we going tomorrow? And then, an hour later, they ask the same question. If that's a change for them, that can be an indicator also. So starting to
Okay.
repeat conversations, starting to repeat questions can be an indicator too.
Okay. Okay, that's so interesting to me. I'm just thinking of, my parents, and then I'm thinking of my grandmother who's still living. And my grandmother would be in her, she just turned 90, I should say. So, she's in her 90s. My parents are in their late 60s. So it's interesting to me that how my grandmother's cognitive decline has happened,
Mhm.
So I feel like she was really kind of sharp until she got to be about 85, and then you started to see some marked cognitive decline, is what I noticed.
Uh-huh.
Now those that might see her more regularly might have had a different experience. But I think to your point, it's any change from what
Mhm.
what's currently happening. If there's a change in patterns in what they're doing, that would be a sign that maybe there's some sort of cognitive concern there.
Yeah, yeah, and it's definitely talking about changes. I have not always had the best attention. I was probably a bit of an ADHD kid who's carried that into adulthood somewhat. But yeah, I have some of those traits, but I still manage to do well. So it's not
Right.
so much about having it as much as of it is, there's a change, and that change is causing greater difficulty with paying bills or something like that. So
Sure.
it definitely needs to be a change.
Absolutely. Now, if you don't mind,
Mhm.
I have from our client, not disclosing any names, but just to have an assessment that you had done. And so I just wanted to ask you a couple of questions, just
Mhm.
generally about the assessment. So for those watching, it's a beautiful summary, and he does kind of history of the present illness. He does psychosocial history, psychiatric history, medical history, family history. So there's a lot of history in there.
Yeah,
So
yeah,
that's something that you talk directly to the client and you ask them these questions about all of these things. Okay.
yeah. Right from birth, any complications at birth starts from there, and then any difficulties learning to walk or learning to talk as a child, any
Mhm.
significant childhood illnesses, scarlet fever, things like that. So yeah, history
Okay.
is a huge part of it. It's not just about what we see with the person now. It's what have we seen all the way up to now as well.
And then in the psychiatric history, you had talked about depression and anxiety. So some of those contributing factors that we might see, that's where you had mentioned that. Because again,
Mhm.
those could all be factors in how somebody's cognitively doing.
Yeah, I mean, actually, the diagnostic criteria for both depression and anxiety is difficulty concentrating. That's like one of the diagnostic criteria. So right there, it's in the diagnostic criteria is acknowledging that it causes problems with cognition. So just by improvements with depression, improvements with anxiety, you can see significant cognitive brightening with that.
Now, people tend to group depression and anxiety together. Are they two sides of the same coin? Explain to me a little bit about how they work together or don't work together.
Yeah, depression and anxiety can go hand in hand pretty tightly, or they can be independent of each other. It
Okay.
just depends on what's going on for that individual at that time. But anxiety can drive depression. If you're constantly thinking about the worst that's going to happen, that has an overall effect on our overall
I could
mood.
see that.
But same
Mhm.
thing with depression. If we're seeing things, everything we're seeing is negative, that can cause anxiety. So there is a relationship between depression and anxiety, but they can also happen independent of each other.
I was going to say, so you could have anxiety, but not depression. You could have depression without anxiety. It's just a lot of times they tend to be there together.
Exactly, exactly.
Okay. And then we went into medical history, and I found this interesting because you had about any history of strokes, head injuries. You talked about that. You talked about blood pressure, cholesterol, um, talking about sleep apnea, which I hadn't considered as a contributing factor. So I thought that was interesting there. So sleep apnea could affect cognitive function.
Yeah, and with sleep apnea, it can do it in a couple of ways. One, if your brain's not getting the oxygen that it needs as it sleeps, the next day you're not going to have, the mental energy that you'll need to perform various tasks. But over time, there's a cumulative effect of that also. If your brain's not getting the oxygen that it needs while you're
Mhm.
sleeping over time, that can lead to some cell death, which then can lead to some problems with cognition. So sleep apnea, it's very important to be treated for cognition today, but also cognition on down the road.
Okay, that's interesting. Then you had a family history section, which I'm guessing you in there, if there was any history in the family of things like dementia, Alzheimer's, those type of things, you would have indicated that there. Is that correct?
Correct. Yeah, there's a genetic component to some dementias that would leave somebody at greater risk of developing a dementia. So that's it's an important thing to look at as it's another data point to kind of line up what might be contributing to an individual's problems.
Are there some things that seem to be genetic as far as certain conditions? Like, is there a genetic component to things like Alzheimer's, dementia, those type of concerns?
Yes, things like Alzheimer's disease, there certainly is some genetic component to it. Things like Huntington's disease, which is another form of dementia that develops with a movement disorder. Those things do tend to be passed on from our grandparents down to our parents down to us. Uh, but just because somebody in our family history has a history of dementia doesn't mean that we're going to develop it.
Mhm.
But if they do have a history of dementia in their family and they're showing signs of dementia, and that's what the test results are showing as well, that starts to line things up together.
I gotcha. Then you went into a mental status and you had some behavioral observations. So you put in things like he arrived on time. You talked a little bit about how he walked, what his gait was, if there were
Mhm.
any tremors. You talked about facial expressions, what you saw there as far as were they symmetrical.
Mhm.
Talked about verbal things that he said and the way that he said it. Talked about whether or not he was alert to time, place, person, all of that. Talked about mood. What mood was he in when he was there? And just, I guess, the effort, as far as his engagement with you during that process. So I thought that was an interesting part of it.
Yeah, people respond differently to testing. Some people get pretty frustrated with some of the tasks, and they'll just, I'm not going to do that anymore. Can we move on to the next one? So that score on that test won't necessarily be as reflective as what their ability is, but it can be informative because they became frustrated, they had difficulty with it. So that can be informative, but then you can't really use the scores or rely on the scores as much as you normally would.
I gotcha. So it's almost like you're setting the stage, right? Like what was
Mhm.
the environment when these tests were conducted? Because that would be reflective of their accuracy of what you're trying to measure. Is that
Mhm.
correct? Fair to
Yeah.
say?
How much reliability or how much weight can we put on these findings? And in some cases, it's very clean and clear cut, and you can have a lot of faith in it. Sometimes what we are left with saying is it's no lower than this. Could be higher, but no
Okay.
lower than this. Um,
Okay.
and so it does change how we report on the findings and how much weight we put behind the scores.
Okay. Now, when you were talking about the way in which the person walked, their gait, is
Mhm.
that important? Is it just kind of setting the stage? Or if somebody was having trouble walking or maybe was like bumping into things, would that be then something you would think would be a contributory factor?
Yeah, it could be. There's different conditions like Parkinson's disease, Lewy body dementia, where there's a movement component to the problems they experience. So we want to be able to look for those kinds of things. For
Sure.
example, and that can actually help differentiate between one diagnosis to another. For example, with Parkinson's disease, you would expect the tremors to start on one side of the body and move to the other side of the body. Whereas with the Lewy body dementia, it starts on both sides at the same time. So just by getting a history or observing, do they have tremors on both sides? That can be a data point that can help with differentiating diagnosis. So
Knew
doing
there had to
things,
be that you had it in there, Tim, because I was like, this is in here for a reason. And that's so helpful to know that even those type of things are
yeah,
important when you're observing. Yeah.
yeah. I mean, looking for the facial expressions, are they stronger on one side than the other? That could be an indication of stroke. Are they
Mhm.
having difficulty pronouncing certain sounds?
Mhm.
That can be indicative of the stroke. So yeah, so we're looking for all of these different things in the mental status examination that are observable signs of possible neurological conditions.
Right. That makes perfect sense. And like I said, I knew there was a method to why you included it. I just wanted to kind of understand why it was important. So thank you. The next
Yeah, sure.
section in the report went over tests and techniques that you administer. My question about this is, do you administer different tests to different people based on what you're doing the report for?
Yes. Um, we'll select the tests based on their history and what the purpose of the evaluation is. So, for example, if it's for a legal
Right.
purpose, there are certain areas where we're going to want to test more than we would say for somebody who's coming in for an ADHD evaluation.
Gotcha.
So we definitely want to do a comprehensive and broad evaluation, but also a targeted evaluation. So we get pretty specific with some of the tests that we use.
Now, you mentioned ADHD. What would your role in that be? Is that a diagnosis that you're able to give after testing? What are you, when you're talking about ADHD, what's your role in that?
Sure. So we would test those abilities as well. There are some tests that are pretty good at identifying attention deficits. So we
Mhm.
utilize those tests, and it's never just looking at a score. It's looking at a score in the context of everything else that's been collected and how does it fit with that. So just because somebody doesn't do well on a measure of attention doesn't mean they have ADHD. It could mean that they're tired, they have a cold, a number of different things.
Sure.
But looking at that score in the context of other things, that can line up and be reflective of a specific diagnosis like an ADHD,
Right.
or it could be a learning disability, something like that.
Now, do you prescribe or you kind of send it back to the primary care physician after you've done your evaluation to do the more medicine or like therapies that could help with whatever the diagnosis is?
Yeah, so I don't prescribe myself. I don't know of any neuropsychologists that do. They certainly can if they go for the additional training. But oftentimes, what we do is we work with our care team. So we'll identify strengths and weaknesses, try to identify what's causing those cognitive difficulties, and then we come up with a list of recommendations for both the person who's being tested, but also for their care team. So we'll have recommendations for neurologists or for primary care physicians on some things that they can target that can help preserve cognition or even lead to some improvements with cognition.
I have a family member that has a severe seizure disorder,
Mhm.
and I know that sometimes they're trying to evaluate cognitively what's happening because depending on the severity of the seizures, how long this individual is
Mhm.
having the seizures, there can be some cognitive decline. So they're always trying to evaluate what's happened as a result of these incidences and can we
Mhm.
recover some ground there? Or what are
Yeah.
some things that we can do to try to reinforce recovering the
Mhm.
ground?
Yeah, and then those are some really helpful ways to use the results from neuropsych eval to kind of guide that process of treatment planning and getting all of the things in place that could be helpful for the individual. So
Okay.
that's definitely one of the ways that we use neuropsychological testing.
Do you ever get referrals from schools?
No, I haven't.
Okay.
Not quite sure why that is, actually. I mean, I know they have school psychologists that do some developmental testing, and maybe that's enough to meet their need. I do know that there are other clinics that will do autism evaluations, things of that
Gotcha.
nature, and those are pretty specialized.
Okay.
You need to have specialized training and specialized testing for that, but
Gotcha.
those are out there too.
That's interesting. Okay. Then you had a section in your report where you're just understanding the results. And correct me if I'm wrong, but I think this is just saying where most people fall in the test as far as the percentiles and kind of what would be the average. Is that correct?
Mhm.
Is that what that section is doing? Okay.
Yeah,
Okay.
so we're trying to compare people against similar people.
Mhm.
So I mean, people the same age, same educational backgrounds, because education is another thing that plays into cognition.
Mhm.
Well, sorry, I just lost the train of thought on that. What was the original question?
I was
Sorry.
asking, is that section just explaining what the average is,
Uh,
like a
yeah.
benchmark? Yeah.
So I mean, we try to come up with a easy way of saying things. So we kind of break it down into categories. So scores between this number and this number. Typically, it means that they're able to perform the function as they normally have, that there wouldn't be
Okay.
changes. Whereas if it's below that, it's between this score and this score. Th- that suggests that the person's going to have some difficulty performing that task. They can still do it, but it's going to be harder for them to do. And then finally, as you get further and further down, it gets to the point where it starts to become impairment and no longer being able to perform that cognitive ability.
That makes sense. Okay, I gotcha. And then when I was looking at the evaluation results, I guess in this particular individual, there was, you're doing a whole battery of tests, and there was one where you just one portion of that test, which was actually the executive functioning dealing with the clock, and it just said
Mhm.
abnormal. But that didn't make the whole, that didn't indicate that you didn't have capacity. It was just that one test, which is why you probably do multiple, correct?
Yes, yes, we do multiple tests in a similar domain, and what we're looking for are patterns. Um,
Okay.
we want to see how this score is with this score. Um, it's not so much of having one score down or a couple of scores down. I mean, because that could just be normal functioning. So that's not necessarily indicating much of a problem. But when you start having scores hanging together and they're starting to sink a little lower together, then that can be suggestive of problems.
Okay. And some of these, I mean, you have noted the different percentiles that the individual was in for the different tests. Some of them were like 34, some of them was third to ninth. So you just have noted each test what percentile the person fell in. So I thought that was
Yes.
interesting.
Yeah, and those are the profiles that we're looking at. So the scores that are high versus the scores that are low, and does that difference make sense? Sometimes that's just normal.
Okay.
Other times it's not.
Now, when I'm looking at it, it has a column that says raw. And then
Mhm.
there's another column that has some initial abbreviations. So the client, what number they scored, is that in the raw column or is that in the secondary column?
The raw score is the actual score that they performed or that they
Okay.
were able to obtain. So some tests have scores that go up to 100. Some tests have scores that go up to 25. And so it's
Okay.
hard to compare those two scores together, but there's
Mhm.
statistical procedures that you can put in place that you can convert that so you can do a more direct comparison between the two, regardless of how many points they were able that were available to get on that test. And that's where the
Okay.
percentiles come in.
Gotcha. Then you did provide right underneath that a summary of the evaluation results. And this is where you just mentioned a couple of the tests that there might have been a few cognitive deficits. You also mentioned in this section that some of the tests he might have had issue with because he had visual impairment, which I thought was interesting, because that can affect it as well. And
Mhm.
so you noted that in there as well. So, and then under that, you had a diagnostic impression of what you thought this individual was dealing with. And then you had some functional elements of capacity where you had mentioned if they did or did not have significant findings to suggest cognitive impairment of any type. So I thought that was interesting to me. And then you had that broken down. And then on the last page, right before your signature, the bottom line is you gave me the capacity determination, which I thought was helpful. So like you gave the summary and then you gave me bottom line,
Mhm.
which can then be used. In my case, like I said, we were using it for capacity to execute documents, whether this person could make decisions about who should handle those different areas.
Yeah, and then using those functional elements, yeah, that American Bar Association and the American Psychological Association put out really helps kind of conceptualize things.
Yes.
And so that's a helpful way of presenting the information. And if they have different, the four elements are, can someone understand what's being presented to them? Are they able to fully appreciate the gravity of those kinds of things? Another one is being able to think critically or reason through these questions, and then finally being able to express a choice. So we do all the cognitive testing, the little domains, and then we kind of bring them under those four functional elements to arrive at whether or not there would be capacity or a lack thereof.
And just so everybody kind of understands from a legal perspective, we're always worried about, does somebody have capacity? Because that's some of the ways that people can challenge the
Mhm.
documents. So we're always worried about capacity and undue influence are the two prongs that we're kind of worried about. And the undue influence part still relates to capacity because you have to have a weakened intellect in order for someone to be able to exert undue influence on you. So this
Right.
type of cognitive test is helpful not only to say, this person does or does not have capacity, but it's also going to help in the undue influence area because if the person doesn't have a weakened intellect, then there would be no undue influence that could be happening. Does
Yeah.
that make sense, Tim?
Mhm. Yep. It certainly does.
So so it helps us from a standpoint of we, of course, never want to do documents if somebody doesn't have the capacity. That's part of our job. And legally, we can make the determination. But sometimes we like someone like you to do it because then we have all of the tests to back up
Mhm.
what's happening. So that's
Yeah.
how we used it. And just know, Tim, that I have a feeling we'll be using you in the future as well because it's just such an important component when we're executing documents. So, and you broke it
And
down so we could understand.
I'm sorry, what was that last part?
I said you broke it down nicely in a way in
Oh,
which I could understand, because I'm not medical. So I'm like, I don't know, just tell me bottom line, what are we working with here?
yeah. Yeah, and again, the idea is we want people to have capacity.
Yes.
Unless they don't, then that would be harmful for them. But we want to help people identify anything that might get in the way, and then here's some things that can be done to help mitigate that. So
Yes.
that's how we approach it. But ultimately, we want what's best for the person. We're working for the person, so we want to get them the best information we can get them, so that they can make the decisions they need to make.
Absolutely. Absolutely. Well, I appreciate your time, Tim. One of the things I wanted to end with is I wanted to be able to give your contact information in case anyone needed to reach out to you. So you can go ahead and say it for us, and then we'll put it down in the description along with your address so that everybody knows how to do that. But go ahead. How can someone get in
Okay.
touch with you?
So my work cell phone number is the easiest way to get a hold of me. During the day, I'm usually with somebody, so I may not be able to answer right away. But you can reach me at area code 223-228-9701, and that will come straight to me. And like I said, if I'm with somebody, I'll give you a call back a little later when I'm not sitting there with the tests firing off questions. I'll give you a call back, and then we can talk about whatever it is that you need.
And we'll drop that in the description. If anybody needs to come see you, you're located at 19 South Main Street in Chambersburg. Is that correct?
That's correct. That's correct. And I have a website. I don't remember what it is offhand, but I can give it to you.
Email it.
Uh,
Put that in the description as well. Sound good?
okay, good. So there's some helpful information on there that can be informative too.
Great. Well, like I said, Tim, I really appreciate it. I know I've experienced this in the last couple of months, and it's certainly something that I have feel passionately about, like that we want people to have capacity as long as we can. We need to be empowering them to be able to be making these decisions. And I think someone like you and your expertise can be really helpful for families to understand, are we at the point where somebody does need to step in? Are there certain interventions that we can do? Are there certain decisions that maybe we can allocate to someone else? But I just think that we need to do a better job of protecting and respecting people as they get older and allowing them to age in with some dignity. That should be what our goal is. And so I appreciate you being here to talk to me about it. Perfect timing as far as when I met you and our discussion. So thank you so much for taking the time today. We really appreciate it. Is there anything you would like to say to close us out?
Some things that are helpful for cognition as we age, real quick: cardiovascular exercise, three
Oh,
times
yes.
a week. Anything that's going to get your heart rate up. That doesn't have to be running a marathon. That can be doing yard work, something that's just going to get your heart rate up. Mediterranean diet has been found to have a protective function for cognition. There's plenty of information on the internet for that. The more socially engaged we are, that has a preservative function for cognition as well. And then finally, challenging yourself. You want to get those brain cells talking to each other. So doing something new, doing something different really gets those brain cells talking together. And the more they talk together, the stronger those connections remain. So taking up a new hobby, learning an instrument, doing something that's new and different is helpful for our cognition as we age.
I'm so glad that we ended it with that, because I feel like those are quick tips that we can all take to heart and try to implement in our lives. So thank you for closing us with that. Plus, I feel like it's optimistic, right? Like, let's
Yes,
all live healthier so that we can maintain our cognitive function for as long as we're able to.
that's great.
All right, everybody. This was Dr. Tim Davis, and I'm Samantha Wolf with the Law Offices of Samantha Wolf, and you just joined us for our next installment of Partnering with the Pros. And you can catch us on YouTube and on our Facebook and website. So feel free to call us at 717-655-2676. Thank you.